privilege to introduce our speaker for this week, Dr. Benjamin Corchia, who I've known, a long time. He completed his medical school in Ben Gurion University in Israel, and then I knew him when he was a resident at Icahn School of Medicine Elmhurst program. And then he went on to complete NICU fellowship over at the University of Miami, and he has settled into Florida, Miami. He's currently the director of bronchopulmonary dysplasia and the director of neonatal innovation at Nova Southeastern University Hospital. Benjamin, it's great to see you again, and really appreciate you agreeing to teach our staff. Thanks so much.
Thank you, Dr. Ree. I'm very happy to be here. And I'm actually very excited about sharing some of my data and some of my passion for innovation, especially in the field of neonatology. Okay, so I think we have to start with some business. I have no disclosures. And Dr. Ree went a little bit over my bio. And as he said, I did my NICU fellowship here at the University of Miami, and I've been the director of BPD at Joe DiMaggio Children's, and now more recently at Nova Southeastern University Hospital, where I also hold the title of Director of Neonatal Innovation. So the objective of this talk really is to demonstrate how lean philosophy can be applied to neonatology, and it can actually spark disruptive innovation. So where we need to begin is by dispelling some misconceptions. There is this belief in medicine and in neonatology more specifically that in order to be a member and an actor of innovation and research, you really need to have all these little things where you would have to have NIH funding, you have to be really in a very large center in a big hospital, and you need to have tons of subspecialties, have to have big technology, big buildings, lots of simulation labs. And not that it is wrong, it's not wrong, but it creates a misconception of this idea of there's big hospitals and there's smaller hospitals, and this dichotomy of big versus small creates this misconception that if you're a smaller hospital, you have no business even trying to be innovative or to try to contribute, and that's really something that we need to dispel. And so that's where I would like to begin. That is also There's also this idea that big hospitals and the field of neonatology as a whole has not been as productive as it has been in the early 70s, 80s, and 90s. This is data from the University of Miami looking at survival of babies based on birth weight. And you can see that on the x-axis from the 1970s to the early 1990s, we had a very, very sharp slope in improvement of survival. But over the past few years, it's been sort of stable slash stagnant. Data from the Neonatal Research Network looking at the major comorbidities of neonatology is also showing this kind of trend where you see in this paper that was published in 2015 that over the past 25 years, looking at about 30 to 40,000 babies, the major comorbidities, necrotizing enterocolitis, late onset sepsis, severe IVH, PVL, ROP, BPD, they're all been sort of stable. Late onset sepsis has gone down, but not dramatically. Actually, BPD is even on the upswing. Looking at long-term data, this is a meta-analysis that was published in JAMA Peds in 2018. On this graph, you can see the standardized mean difference on the y-axis and the birth year on the x-axis, and you can see each little circle here represents a different study. And looking at about 8,000 babies, if I remember correctly, that were born extremely prematurely, you can see that the IQ of these babies at about between 5 years of age and 20 years of age has remained also quite stable. And so we enter this realm that Morton Myers, in his book Happy Accidents, describes very well by quoting Mr. Beveridge from Cambridge University, where he describes that where knowledge is no longer growing and the field has been worked out, which I think is not quite true for neonatology, it's been stagnant, a revolutionary new approach is required, and this is more likely to come from the outside. Skepticism with which the experts nearly always greet these revolutionary ideas confirm that the available knowledge has been a handicap. And I think this is really highlighting one aspect, which is that neonatology is really primed for breakthrough innovation. So the question that we must ask is, what is innovation? And that's a very, it may sound like a trivial thing to ask, but it is a significant question that's difficult to come to an answer to. In his book, Mapping Innovation, Greg Statel describes innovation in a very simple way, and this is the way that I like to think about it, which is that innovation really is about solving problems. If you're able to solve a problem, you're being innovative. But that itself can also be a little bit tricky. For example, if I asked who should be credited for this innovation that we're seeing on this picture, there's really two answers. And the two answers are either the Wright brothers on the left or William Boeing on the right. And that sounds very counterintuitive, but when we think about it in Greg Satel's sort of frame of reference, it kind of makes sense. The Wright brothers solved one problem, which was human flight, and William Boeing solved human air transport. And you can see that you can be innovative, and it just depends on what kind of problem you're trying to solve. So there's an importance to defining the problem. And Einstein said this very well when he said that if he had an hour to solve a problem, he'd spend 55 minutes defining it, 5 minutes thinking about the solution. And that's really where we are right now when it comes to innovation. So Greg Satel in his book described this innovation matrix where he really puts everything on an XY axis and says it's about how well your problem is defined, as we see here on the y-axis, and how well the domain is defined on the x-axis. And he goes over 4 kinds of innovation, and we're going to talk about them. The first one that he talks about is basic research. Basic research has 2 main characteristics. Number one, the problem is not well defined, the domain is not well defined, and it leads to the exploration of a breadth of avenues in order to come up with some innovative solution. The best example I can give you in neonatology is bronchopulmonary dysplasia. From a physiologic standpoint and from a histologic standpoint, we understand that bronchopulmonary dysplasia is the result of preterm birth that arrests the development of the lung and leads to this sort of pattern of alveolar simplification that is the hallmark of bronchopulmonary dysplasia. However, we really don't understand clinically how to define it. This is the NIH workshop definition from 2001 that looks at the amount of the fraction of inspired oxygen at 36 weeks corrected. This definition was revised in 2018 to include the mode of ventilation. In 2019, Jensen from CHOP defined BPD in another way, just without regarding the FiO2, just the interface that the baby is being placed on. And you can see that, number one, there's a multitude of definitions. The way we treat bronchopulmonary dysplasia is all over the place. We use caffeine, diuretics, bronchodilators, steroids, vitamin A. We really don't have a single agent that helps us solve this problem. We are researching all sorts of different agents, steroids again, diuretics, surfactants, cell therapy. This is actually a table from a paper that has referenced in the recent years all the different trials that have been registered looking at the use of mesenchymal stem cells for the treatment of BPD. And you can see that this disease really lends itself very well to basic research. It's a lot of different things. We're not really sure where to look for the answer. And this really benefits from broad support from government grants. And this is really what the traditional model for research and innovation really fits well. So then we go into a different type of innovation, and that's breakthrough innovation. Breakthrough innovation is a very specific type of innovation where the problem is very well defined. We know what the issue is, and we need to solve that problem. However, the solution is extremely difficult to come by, and so you need to explore unconventional skills and domains. The best example for this type of innovation is the story of the incubator. The story of the incubator starts in France in the late 19th century, so in about 1860, 1870. Birth and mortality had become a political issue, And that's because the French birth rate was going down. And not only was it going down, but the birth rate of England and most notably of Germany was on the rise. Actually, the birth rate of Germany was twice the one of France. And so the politicians saying we need to have more babies because we need a strong military. So a completely misplaced motivation, but that led to some cool innovation in neonatology. And so they thought if we cannot increase the birth rate of mothers in France, we have to actually start working on trying to reduce the mortality of the babies that are being born in France. And so this is a little cartoon from a French comic book that looks at the history of medicine. And you can see here Dr. Stéphane Tarnier, who actually has, in 1880, visited the Paris Zoo. And there he met with the zoo sort of director, which was this lady here, Odile Martin, who showed him the chicken coop incubators, saying, this is where we put the chicken eggs so that they can be incubated and hatch. And Stéphane Tarnier thought, that's kind of cool. Can you build me an incubator for a baby? And that's where the first incubator was designed. So this is Stéphane Tarnier here on the left, and this is the first incubator. You have a bed on the top part of the incubator that could hold up to 4 babies. And at the bottom, you have a bunch of water bottles that had warm water, and then the air would circulate and create sort of a humidified environment for the baby. These incubators were then used in at l'Hôpital Paris Maternité, which is one of the first hospitals in Paris in the 1880s. And as you can see, they would put multiple babies in the incubators. They would refill the hot water, and that's sort of where the incubator really started. In 1887, one of Tarnier's students published their results. That's one of the first reports from late 19th century where they looked at the effect of using an incubator on child mortality. And here the blue bars are representing babies who did not benefit from the incubator. And each column here in French represents the number of months of prematurity. And you can see that babies who were born at 6 months of gestation had 0% survival. There's not even a bar there. But in red and in black, you have 2 different cohorts of babies who did benefit from the incubator. And you can see that mortality and survival was much higher. Then another French guy in Nice in the south of France made some improvements, adding some glass doors, and really was more of an entrepreneur than anything else. And so he took his incubators and started displaying them. And he thought to himself, if I put some real babies in there, maybe people will pay to come see that. And that's actually what happened. So he opened these little shops where you would pay 50 cents and you would come and you would see babies in their incubators. He then took this to the Berlin Fair in 1896, and that was a huge hit. People were raving about this exhibition, and many people tried to reproduce that down the road. So this is the follow-up in the early 1900s, in 1933, in Chicago, where you could see actually the hall where those babies were exhibited. And this is another one in San Francisco where people would come and look at tiny babies that were alive in their incubator. And this is a picture from Coney Island, not too far from where you guys are at, in 1939. And you can see that when the census in the NICU was too high, they would put multiple babies in the incubator. The incubator went through several iterations, but truly, it hasn't really evolved. That was sort of the same concept that Tarnier devised almost more than 100 years ago. And this is ours today, and it still functions the same way. We have hot water at the bottom to create humidified air in a closed environment, and so it really hasn't changed much. But it did achieve the problem that was defined early on, which was that infant mortality rate did go down. Obviously, this is not all attributed to the incubator, but the incubator is a significant advance in neonatology that can be credited for the decrease in mortality. So then we get to something, a third type of innovation called sustaining innovation. And for sustaining innovation, we have something that we found is working. We have an existing service, and then we start improving on that on an incremental basis. And the problem sort of gets better understood as we make these incremental changes. And for that, I want to tell you about the story of phototherapy, which is one of the coolest innovation stories in neonatology and in medicine, in my opinion. And so the story takes place in the 1960s. This is the Rochford General Hospital in Rochford, UK. And there worked a nursery RN who was Sister Jean Ward. And Sister Jean Ward was a very peculiar nurse because she was used to raising puppies at home. And so she was of the belief that babies would benefit much more from fresh air and from sunlight than from being in the indoors and in the incubator. So she would sneak those babies out and expose them to sunlight outdoors and then bring them right back into the nursery before the doctors started rounds. One of the doctors in that nursery was Dr. Richard Kremer, which you can see here on this picture. And then one day, Richard Kremer looks at a baby and notices that one area of the baby's skin is more yellow than the other and asks Sister Jean Ward what happened. And she says, well, that's a piece of the skin that was not really exposed to the sunlight when we took the baby out, and so that's the reason why. And so that sort of started the turning of the gears in Kremer's mind. And then something else happened, which is a few weeks later, they were doing an exchange transfusion on a baby, and they pulled a blood sample to be sent to the lab to check a bilirubin level. And they misplaced the sample, and they had left it on a windowsill under sunlight, and they noticed that the serum was green instead of yellow, and when they did send it to the lab, the bilirubin was far, far lower than expected. And those two events made them realize that sunlight must be playing an active role in the reduction of bilirubin levels in newborns. And so they published these findings in the early 1960s, and that has led the sustaining innovation that followed in the field of hyperbilirubinemia. Gerald Lucy is an American pediatrician who is responsible for the championing of phototherapy in the US. And what was interesting is that there was a delay in the implementation of phototherapy between these initial papers and the papers from Gerald Lucy. And what most people are thinking happened is that a lot of the papers that came out from that time in England until the late 1960s is that a lot of the papers were published in foreign languages, in French, in Spanish, and Portuguese, but not really in English. And Lucy went to a conference and met a Chilean physician, Mario Ferrero, who was a very enthusiastic pediatrician and neonatologist. So he invited him to come do a fellowship in Vermont. And there, Mario Ferrero said to Gerald Lucy, how come you guys are not using phototherapy? And he says, I don't know about phototherapy. What are you talking about? He says, is there any evidence for phototherapy? And he said, absolutely. Mario Ferrero then translated all the papers that had been published internationally and presented them to Gerald Lucy's team, who then started testing phototherapy in the NICU here in Vermont. And that really has then been the initiation of phototherapy in the US. With the advances that happened in the 1960s, we started understanding what all these observations sort of were causing, and we understood which type of wavelength specifically was reducing bilirubin levels. We understood that it was a change in configurational isomerization of the bilirubin that then made it sort of excretable. And then you had the structural isomerization that allowed it to be passed in the urine. All these things made us understood that we didn't really need to use these archaic sort of neon lights to actually get the baby's bilirubin levels lower, but we were able to sort of increase our resolution in understanding and sort of making it more granular in how we're using phototherapy to eventually improve on this concept with this. The latest tech and innovation is this phototherapy sleep set that uses fiber optic to really surround the baby in blue light and expose as much of the skin as possible to reduce bilirubin levels as fast as possible. And so that was sustaining innovation. The last type of innovation is disruptive innovation. And disruptive innovation is interesting because it requires very much less expensive sort of technology, and it's trying to solve an ill-defined problem in a very well-defined domain. And eventually, disruptive innovation starts with a very low, inexpensive tool that eventually is able to displace established competitor. So this is where I want to introduce the concept of lean. And lean was described in a book that we'll get to, but first let's let's look at why lean in business can be also applied to medicine. So this is a little diagram that describes for young entrepreneurs what they're supposed to do if they want to start a business. And it says that you have to make sure that this is what you want to do, decide what kind of business you want to get into, research your idea, write a business plan, get some funding, assemble a team, and then get through some paperwork, which, when you think about it, is extremely similar to how we do research. We sort of think about what we want to do, we do some literature review, we write a proposal, we get a grant, we build a team, and hopefully we have significant results that we can publish. This traditional model is one way, but it is not the only way. And in the Lean Startup, Eric Ries describes what the model of Lean is, and it's about identifying a minimal viable product, meaning what is the one thing you can put together that would help solve a problem with the lowest tech possible. You should develop that product rapidly, release it rapidly, give it to customers and users in a real world environment, and get feedback based on that experience. And then with that feedback, either improve on that product or pivot to something else because you've been shown that this was not sustainable. And so this model is where, this lean model is really something where disruptive innovation can be sparked. So we have an insight, a problem, solution, and then business model, okay? And then at the bottom, we have the different timelines. This goes back to what Nassim Nicholas Taleb in his New York Times bestseller book, The Black Swan, talks about when he talks about tinkering. And in the book, he says the strategy for the discoverers and the entrepreneurs is to rely less on top-down planning and focus on maximum tinkering and recognizing opportunities when they present themselves. And I think this is exactly another way of defining the lean philosophy. And he's saying that the ability to tinker as much as possible and to try to collect as many black swan opportunities as you can is what is leading to sustainable success. So how do we approach then, how do we get from lean to disruptive innovation? This is a graph that really is showing what the aim should be. We have two types of customer. Some are more demanding and some are less demanding. Sustaining innovation progressively targets the more and more demanding customers. Disruptive innovation starts with the least demanding customers and then makes its way to the most demanding customers. So in order to apply this philosophy to neonatology, we have to wonder first and foremost, who is or are the most demanding users in our field? And for that, there's no question. It's the babies. The babies are the most demanding users of the neonatal ICU. They have high requirements in terms of safety, efficacy of interventions, and there's really no room for error when it comes to critically ill newborns. To a lesser extent, it's the families and the parents who are directly intertwined with the health and the progress of their babies. So in order to apply lean, we have to wonder who are the less demanding users in neonatology that we can target right off the bat. And for that, we believe that it is everyone else who's interacting with the baby. And that includes the families, and that includes the staff, the doctors, the therapists, the nurses, the clerks, the environmental services, everything that is involved indirectly or directly with the care of a baby should be targeted for lean and disruptive innovation. So we have to then understand, in order to cater to this group of users, what are their needs? And so in this very cool study about innovation that was published in a year ago, January 2020, in Pediatric Research, they provided semi-structured interview to about 50 staff members from 11 randomly selected NICUs in about 6 countries, asking them, what do you need to be innovative? What do you need to, what is your vision of innovation? And you see on this graph that in the darker bars, that represents the doctors, and in the lighter bars, that represents the nurses. And you can see that there's a big gap. So for example, here, when it came to new technology, the doctors were much more prevalent in asking for that extra guidelines and regulation, needing to standardize practices. And then our nurses said, wish to improve care to a much more significant extent, reducing adverse events. And what was very interesting is that everybody equally was interested in participating in research. So with that in mind, let me just see, yeah. We decided to build a sort of game plan for how we're going to apply lean to our NICU. And the first 4 items that we decided to tackle were, number 1, crowdsourcing, collaboration, reducing administrative tasks for the physicians, and providing a new model for family-centered care. So let's talk about crowdsourcing. I am not sure if you guys are familiar with this app. It's called the Human Diagnosis Project. It's an app that you can download on the App Store. And what it does is that it provides doctors, med students, anybody who is in healthcare to submit a case and crowdsource the differential diagnosis. So this is sort of a screenshot of my phone, and you can see that you have a case here, and you can provide some answers and hopefully help another clinician with a difficult diagnosis. But I'm not going to talk about this app right now. What I want to talk about is this study that came out in JAMA that looked at some of the answers collected from this app. And they looked at about 2,000 responses, and that included attending physicians, fellows and residents, and medical students. And what they looked at was, what is the diagnostic accuracy of each user? And on this graph, what you can see is that at the individual level, so here on the x-axis, you can see the number of solvers, and on the y-axis, you have the accuracy percentage. One user's accuracy is about 60 to 65% on average. But what was really interesting is that as the pool of solvers increases, suddenly your diagnostic accuracy shoots up close to 90%. And that really makes the case that crowdsourcing really can improve delivery of care by increasing at least diagnostic accuracy. The researchers from this JAMA paper then wondered, did the med students weigh the curve down? But that was not really true. When they started separating the different groups between all users and then users with no medical students or without attending MDs, you can see that the curve holds true, and that as more people are being pulled to answer a question, we're more and more likely to get to the right answer. So our team wondered, the app is mostly designed for adults, so we thought, where do we have the largest community of neonatologists? And so we thought Twitter is probably the place to go. So we built ourselves some Twitter profiles, and we started interacting with people on Twitter. One thing that came to our attention was this interesting paper from the Peds ICU world, where they had used social media to see how information was being disseminated during the times of COVID in 2019. And that was a very informative paper because they used, these were done by people from Johns Hopkins, and they used this software called Simpler, where they can actually map the interactions between the most sort of active users on Twitter, the diameter of the circle, looking at the number of mentions and followers and so on, and looked at a global map in terms of where the information was being disseminated. And I was not the only one who noticed that paper, and some of other neonatologists, one Michael Narvi from Canada, saying, hey, have you guys looked at this paper? And Alvaro, who's a pediatric resident, said, hey, we should probably write the same type of paper looking at information for Twitter, for neonatology. And through Twitter, through this collaboration, we were able to collaborate with myself from Florida, Alvaro from Tulane, Canada, from CHOP, from the University of Toronto, from other researchers in Australia. And we were able to track, using the same software, the different hashtags that have been used in the neonatal world. And what came out of this paper was that there is a need for unified sort of methods of dissemination of information on Twitter. And it was quite erratic depending on the different times of the year and depending on conferences, how the information was being disseminated. That led to the question of, should we unify ourselves under a common hashtag? And Alvaro created this sort of robot on Twitter that will use the different hashtags that we identified, and anybody who actually uses them in a tweet will get a repost on this account that many other people are following. what this leads to is that we can actually do crowdsourcing live on Twitter. And so this is an example where I had a discussion at work about the approach to screening hip ultrasound in preterm baby girls who were born breech. And I was able to pull the Twitter community to get a sense as to what other people are doing, not just the 2 other people that were sitting with me in the office that day. It led to an interesting discussion where we shared papers, we shared data, and that's how we're sort of using Twitter as a mode of crowdsourcing and collaboration. So there's a way to crowdsource, but there's a way also to collaborate between institutions. And I think for smaller institutions, it's sometimes the lack of patient volume becomes really something that is difficult to overcome when we want to be innovative and test some innovative measures on patients. And so today, thanks to communication solutions, collaboration is much easier to achieve. And we know also that single center studies are falling out of favor. And so in this paper that was published in 2009, and that's an adult review article, it looks at some of the biases associated with single-centered studies. In this paper, one of the examples that they give is looking at some of the ventilator-associated pneumonia results from a study in 1999 and compare it to a subsequent multi-centered study, and you can see that the results are dramatically different. And that, again, is one of these biases and that have been notorious with single-center study, and that's why the movement has been to try to conduct multi-center trials. The same type of papers have been published in neonatology, and we now know that there's lots of issues to consider when it comes to performing single-centered studies in a smaller, even in a large unit, actually. So at Joe DiMaggio, we had a BPD service that was 8 beds, and that really held only medically complex babies that had severe BPD and that were on the ventilator past 36 weeks of corrected gestational age. But again, it was great to have, but it was still very small when you consider the data that you need to actually perform any type of study. So our team looked for collaboration, and we stumbled upon the nationwide Children's BPD Collaborative. And years ago, we were able to join that collaborative, and we were one of the first 12 institutions to sort of get together with Nationwide and with other centers, including Boston Children and Children's Mercy Hospital in Kansas City and Hopkins, to start collaborate on these on the treatment and approach to these BPD babies. And this actually has led us to be part of this very nice paper that came out in the Journal of Pediatrics, looking at the interdisciplinary care of children with severe bronchopulmonary dysplasia. And I think this is the demonstration that despite low volume and small number of patients, by picking the right collaborative group, you can actually have a significant impact as a whole using your institution, using your physicians and your nurses and your nurse practitioners on the field itself. More recently, we have noticed that we do have a significant number of babies with tracheostomies, but definitely not enough. We probably have 2-3 babies with tracheostomies at a time in our service. So we decided, and we found this global tracheostomy collaborative that includes centers from all around the world, and we're now collaborating with them on getting together our data and sharing our data for research purposes. The other aspect that we looked at in terms of making our unit a bit more lean was to try to make time, and that was a big, big issue for us. This paper published in 2019 in JAMA looks at some of the frustrating aspects of electronic medical records and what are the different elements that are the source of provider stress and burnout. And you can see that there's a lot of different background variables, but the EHR uses and factors that are really have been noted to be prevalent by the different users. Inability to navigate the system quickly, information overload can lead to a variety of outcomes. And so the data was showing that we sort of looked at this data very carefully, looking at what exactly is responsible for the discontent of all the providers using EMRs. I have not seen anybody raving about the EMR. Everybody has something negative to say about their EMR, and we decided that we would try to tackle that. Some of the most prevalent items was excessive data entry. And you can see here on this list a lot of other aspects of it, the information overload, the slowness of the system, the inability to navigate systems quickly, the fear of missing something, the interference with patient-clinician relationship. I mean, it's kind of true that we do have a screen between us and the patients, and really doing everything towards billing and not patient care. In another study that looked at some of the inconsistencies and unreliability of using EMRs to provide care, we can see that some of the respondents to this study that was published from Minnesota in 2019, some of the things that people are very frustrated with and that they're identifying as barriers, either slight or severe barriers to their use of the EMR. And I thought this graph was so good because it really says a lot of things that I've probably said myself. Too much information in the notes. Information in the note is not accurate. Others don't record the information the same way or more inconsistently. So we looked at this and said we have to do something in order to free a little bit some of our physicians from all these unnecessary tasks that are taking time away from the bedside and from quality improvement. In this very cool study that was published in 2014, this group, the study was published in the Journal of Applied Clinical Informatics. And the group in Massachusetts took these glasses that had eye tracking technology in it and placed the physician in front of sample notes and would track their eye movements to see exactly what would physicians look at. And what was very impressive is that it's so skewed towards impression and plan. And again, this is something that rang very true to me because we do this, all of us, looking at a note either from a colleague or from a consultant and try to scroll through all this sort of bloated type of information all the way to say, what is your impression and what is your plan? That's really the one thing that was critical for us. So what we decided to do is that we sort of surveyed our practitioners trying to see what their issues were. We identified areas that we could improve. And the first thing that we did is that we sat down with clinicians, EMR sort of coders, and the billing department. And we were trying to design a workflow that would be like in the lean approach, a minimal viable product. What is the smallest thing that we can do in a note to fulfill all the different requirements for safety, good communication, and billing? And we came out with a process, and we tried to roll that out. So we created this presentation. We use an EMR called Premier, and we created the 5 minutes project where we really went over everything and looked at the chart, not just as what is being typed, but as the chart as a whole, trying to find where information was already being auto-populated. And we gave our clinicians very clear directives as to this is what needs to be filled, this is how it should be filled, and when. Some things need to be updated on a daily basis, some things need to be updated on a weekly basis, and we created a model that looked at really how to be the most efficient with our EMR. What we noticed is that the number of clicks per patient and clicks per day went down significantly. And so for a patient, based on all the different problems, and again, we're talking about the neonatal ICU, so our babies do have a significant number of problems, but it went down from an average of 80 to about 30. The number of clicks per day, when you have an average census of about 20 to 30 babies per doctor, it's about 968 to then went down to 300. And we extrapolated that in percentage of the day spent, which is a bit less objective than the other two metrics, but it went down from about 60% to 23%. And that obviously has made some very happy physicians. The doctors feel like they have time to speak to families, they have time to read evidence, and they have time to get themselves involved with quality improvement projects. The last item I wanted to just touch on is family-centered care. And the other approach that we're taking in our NICU is how to involve and how to think of our babies as part of a larger family and not just as individuals. And for that, we have developed a bunch of other new tools, including nonverbal tools of communication, continuous feedback mechanisms for parents, ways to involve parents in care and in rounding, use of technology to promote bonding between babies and family members. We have long-term follow-up initiatives. We have created platforms for opinions and testimonies, and we're trying to find ways that are going to help parents reframe the NICU experience. And I'm just going to leave it at this because I think this is a whole other presentation in and of itself where we can go into the different metrics and the different interventions that we've developed to try to make the NICU experience better for families. So in summary, I think there are many ways that we can effectuate change and innovation, and those changes don't necessarily need to be sophisticated. We can find very cheap alternatives to try to make a difference in our NICUs and for other NICUs as well. Our field is definitely primed for creative breakthroughs and for the injection of other technologies from other fields to improve the care of neonates. Neonatal outcomes can be improved thanks to these quality initiatives, and especially if we also think of aiming those initiatives at parents and staff members. We tend to think that for quality improvement projects to be meaningful, they have to target the baby directly, but we do have ways to impact the babies indirectly through the people that are interacting with these patients on a daily basis. My advice, I was thinking of things that we could share together, that we could do in order to start this process. And I think the first step is go online, create a Twitter profile, try to engage with colleagues, and on an institutional level, try to find ways that you can collaborate with other places. Try to find collaboratives you can participate in. It may be difficult to engage in the process of joining the Neonatal Research Network, but there's many different collaboratives out there in the US and around the globe that are looking for partners to share ideas, to share data. And I think this is something that we actually actively have to seek out because they're not advertised as much as they should. And then finally, we have to seek from family members and from the staff, how can we make the delivery of care in the unit better, and try to find ways that we can simplify the experience for both parents and staff in order to deliver better care. Thank you very much. I wanted to thank my innovation team, Dr. Rooney Toms and Dr. Daphna Barbeau, who I am working with. And the last thing I'm going to mention to you is the fact that our team has recently released a podcast where we go over some journal articles for neonatology on a weekly basis. And then the other week, we interview anybody, doctors, nurses, parents who are in some way have an interesting neonatology story to tell. And the podcast is available on Spotify and is going to come out on Apple Podcasts in the next few days. Thank you so much for your time, and I'm happy to answer any questions.
Dr. Korchet, thanks so much. Really amazing presentation. I think illustrates your innovative mind and the way you think out of the box. I've always remembered you to be along those lines, even as a resident. And it was great to hear about some of these history lessons, which I finally understand how things have happened. And so I guess my question is that how have you been able to implement this approach? It seems, medicine is built on a lot of traditions, and we do a lot of things a certain way just because it's always been that way. And it sounds like, you have a specific mission at your institution in terms of your responsibilities. How do you get that buy-in, or how do you get people to understand that? I mean, this is a great talk, honestly, and it convinces me that we need to think differently and we need to, be innovative. Tell me a little bit about how you've gotten that support, or some of the barriers you face to take this approach.
So this is a very good question, because there's always two major barriers when it comes to this approach. The first one being support from the institution, and number two, resources. And so we've tried to solve these separately. Number one, in terms of resources, we try to find the cheapest alternative. Like we said in the lean model, the minimal viable product. So that's why Twitter was a very good alternative for us. It's completely free to use, and it already has a very large community. So we're always looking for free alternatives. And then if we can find some support, whether it is through donation, private grants from industry, whatever it is, we're going to seek out that support if we need to grow in a specific direction. Now, the more interesting question, I believe, is how do we get buy-in from the staff, and how do we get buy-in from the institution? And what we have noticed is that in the lean model, there's this idea that we always have to get user feedback. And that's something that we've made sure to collect And that's something that we've made sure to present to our administrators. So for example, as we're implementing these measures, we're monitoring very closely our Press-Ganey scores, and our Press-Ganeys have now been consistently above 90 to 92%, because parents are now noticing that the doctor is actually here to talk to me in the afternoon, and they're not dismissing a parent because they're busy because they have 6 notes left to write. And so all these little metrics are creating satisfaction from the parents, number one, but from the staff as well. We found that our nurses are extremely happy that the doctors are a bit more accessible, especially after rounds, because they're not spending 6 hours writing notes. When we collect this information and we put it in writing and we put it on presentations and we present it to our administrators, it's a no-brainer. And the initial phase is completely sort of self-reliant. We do get at least buy-in on the second wave where they say, how can we support you in trying to improve this and make this better? And this is where some of these family-centered approach are becoming sort of more supported by the administration.
I have a question.
Yeah.
Hi, Jeff Fine, one of the pediatric emergency physicians up here at NYU. I was interested in the crowdsourcing curves, and I was wondering, is it crowdsourcing that gets you to that high level, or do you finally get the 1 or 2 excellent diagnosticians finally weighing in who actually make the difference?
Right. So I think it's a little combination of both, but I have an interesting study to share with you where there's this carnival game where you can, the carnies will have a jar full of beads, and the game is you have to guess the number of beads inside the jar. And what you find is that it's very difficult to obviously get the right number. But some psychologists, I forgot from which institution, started writing down the different guesses and then averaged them all out and found that when you take a multitude of even random guesses, the average is within 5% of the correct answer. And so there is data out there to show that it's the actual collective brains that circle around the correct answer to give you some accuracy. But it is true that the more people you garnish, then you will have more astute clinicians to weigh in. So I think it's a combination of both, but I think the crowdsourcing aspect of it itself cannot be completely dismissed.
But this is Michelle Kwan. I was also thinking about the crowdsourcing, and I think like it's the individual taking the correct keywords and putting it together, and then you know, sort of making a composite out of that. But it starts with the individual taking the correct keywords and combination of keywords to prioritize your differential, and then putting that all together. I feel like it's.
Absolutely. I have been involved in so many different Twitter sort of surveys and polls where either the question is not asked in the correct way or the answer choices provided by the person requesting the survey are not very well put together. But the funny thing is that Twitter is a bit like a petulant child. So many people in the comments will say, you're asking the wrong question, and we'll try to reframe the question. And even that process alone, this idea of other people weighing in, saying you're framing your question the wrong way. The question should be framed in way X, Y, Z. It's helpful, and that collaboration is extremely valuable. And I think it's beyond what's being shared. It's about the ability to share with people that you would have had an extremely hard time even interacting with during using traditional methods.
I have a quick question. First of all, your talk was really excellent, and it really has inspired me. And, you know, we used to use NICUnet, which was kind of like a little bit of a collaborative, but to see it on Twitter, I think it's a great opportunity to collaborate more easily with other physicians. But, you know, lately the CARES Act came out, and right now at NYU, our notes are for immediate release. Labs are for immediate release. I don't know if your institution is currently at that stage, but have you seen a difference in feedback from parents, or has that helped kind of with the crowdsourcing, even though it's from parents, as far as making new innovations or changes to your medical planning?
So I'm going to talk about one of the, I was hoping that my family-centered care slide was going to be a good enough of a tease for me to come back next year, but I'm going to give you some of the things that we've started doing, especially considering the availability of notes. That really created panic down here about, oh my God, what does that mean for us, et cetera, et cetera. So what we've understood is that, yes, parents and families will have access to notes and results in a live manner. But what we thought was this project of trying to make the note as minimal as possible should create a new platform. We should not be interacting with families over EMR. We should be able to interact face-to-face. We're hoping that by spending less time on the note, you're able to actually interact with families. So in order to mitigate that and to not wait for a family to quote unquote request a meeting with the physician, one of the aspects that we've done is that we were doing multidisciplinary rounds at the bedside with the families present. So one of the new things we've implemented recently is having rounds. Usually rounds formally, traditionally began with the nurse presenting the baby, how was the overnight event, and so on. So we've shifted that. We've invited families on rounds, and the mother or the father of the baby will be the ones doing the first sort of speaking, saying, this is my child, give us the name, and how was the night? Sometimes the nurse or the doctor says, yeah, the baby had a good night, and you can see the parents saying, no, they did not. And from a medical standpoint, it may have been true that the baby's vitals, everything was normal, but the baby may have been very fussy or may have had so many other things that the parents attended to and didn't really let anybody else know. So by having the parents communicate first on rounds and have the opportunity also to close rounds with some closing comments, we know where they stand. They know where we stand from our clinical sort of assessments, and we're trying to see if this sort of approach is going to help us avoid the issue with open notes is miscommunication. I might say something in the note that the parent's saying this is absolutely untrue, this is not the case. Well, we're hoping that by communicating through rounds at the very least in one of the ways is going to help mitigate that. I don't know if that answers your question, but that's sort of how we are thinking about this process.
Ben, this is Dave Ree. Oh, sorry. Someone is saying something. Go ahead.
Sorry, this is Michelle Kwan. Yeah, I when during rounds, family-centered rounds, we do have a style where we have the nurse present first, and then like I feel like I always have to like follow up with the nurses' presentation, because a lot of esoteric words are thrown out and like, you know, parents don't really know, and it should be like more like broken down or, you know, to the level of a non-medical person. You know, I feel like that also helps with the streamlining the information and not having redundancy in the presentation as well. And then, and then the families, they look perplexed, they look like a deer in the headlights, you know,
and let me tell you what I think. This is me going on a limb here, but I think it helps with families being able to listen. I think sometimes rounds start and the families have something they want to say, and they're sort of bottled up, and they're just boiling through rounds only to get to the end and just say what they had to say without realizing that they were not paying attention to what was being said. By allowing them this outlet from the beginning, saying what's on your mind, and then we can also as clinicians redirect rounds to address specifically those concerns. And that I've seen parents go back in the room after rounds feeling like they've satisfied that we talked about what I wanted us to talk about. And I think all these measures help mitigate all the sort of stigma around documentation.
Right. Absolutely. And then there's the other problem with, you know, our burden of documentation as well, and how to better streamline that and not compromising, you know, the information that's presented in the chart, and, you know, with reimbursement and quality and all of that without compromising any of that. Like learning how to really save time and streamline that would be very helpful, and allowing the physician and providers to spend more time with the patient, and even family members. Yeah.
Absolutely.
It's been, all I'm saying is that thank you for talking to us about innovation. So Dr. Kwan, this is your platform to get an innovative way of getting rounds better here at the Brooklyn campus. I want to say merci beaucoup parce que l'histoire des couvreuses, it was amazing, and I did learn a lot about the history of how things came about. We seldom think about that, but just to know we can start with very simple ideas and really develop something that's tremendously useful and can evolve into something that's life-sustaining.
Thank you. Thank you very much. I'm glad you appreciated it.
All right, Dr. Butcher, thanks so much. Really appreciate it. One of the best talks here. We really appreciate it, man. And I will invite you back. We want you back next year. I want to hear about the family-centered rounds. I'm not kidding. We're going to have you back next year. All right?
It's not just family-centered rounds. There's a lot of cool stuff, but it would have made the talk 2 hours long, and that would have not been fair. So I'm happy to devote another presentation to that because it's kind of exciting.
Awesome.
Thank you.
All right.
Thank you, guys.
Thank you, everyone, for participating.